Hello, and thank you for joining this OncLive peer exchange titled The New Frontier in Non-Small Cell Lung Cancer Immuno-Oncology Combinations. Although the availability of checkpoint inhibitors has transformed the treatment of advanced lung cancer, there is still a need for more effective frontline therapies and better predictive biomarkers for the majority of patients without driver mutations. We have new standards of care for patients with both metastatic and locally advanced disease. And we are now entering an era of combination immuno-oncology regimens and perioperative regimens. In this OncLive peer exchange, we will talk about the latest data surrounding immunotherapy for non-small cell lung cancer, including the abstracts from the ASCO 2018 annual meeting and opportunities for improving outcomes in clinical practice. I am Dr. Mark Socinski, and I'm Executive Medical Director and member of the Thoracic Oncology Program at the Florida Hospital Cancer Institute in Orlando, Florida. Participating today on our distinguished panel are Dr. Karen Kelly, Associate Director for Clinical Research, the Jennifer Renee Harmon Tegley and Elizabeth Erica Harmon Endowed Chair in Cancer Clinical Research and Professor of Medicine at the UC Davis Comprehensive Cancer Center in Sacramento, California. Dr. Corey Langer, Director of Thoracic Oncology, Abramson Cancer Center, and Professor of Medicine at the University of Pennsylvania in Philadelphia, Pennsylvania. And Dr. Benjamin Levy, Assistant Professor of Oncology and Clinical Director of Medical Oncology at the Johns Hopkins Sidney Kimmel Cancer Center, Sibley Memorial Hospital in Washington, D.C. Thank you all for joining us today. So let's begin. Corey, I'm going to rewind the clock a little bit and go back to April 16th, 2018, when at the AACR meeting here in Chicago, we had a session that really set a new standard of care, and that was the presentation, finally, of Keynote 189, which was much anticipated after the results of 21G, Keynote 21G, of Cohort G, which you were involved with. So I'm wondering if you could tell us a little bit about 21G to 189 and how that changed our world.
I think we need to wind the clock back maybe a year and a half ago to 024, which really changed how we practiced. Of course, that was single agent Pembro versus standard chemo in individuals with 50% or higher PD-L1 expression, showing an astounding improvement in response rate and progression-free and ultimately overall survival, which, at least in my opinion, exceeded my expectations.
Yes.
Certainly compared to other studies. I was involved with a number of other institutions in a randomized phase 2 that asked a somewhat different question, whether adding immunotherapy to chemo could potentially improve outcome in a more unselected population. So PD-L1 was collected, but it wasn't stipulated as an entry criteria. We looked specifically at the non-squamous population in the absence of molecular aberrations. It wasn't the global population. We explicitly excluded individuals with oncogenic drivers. This is a randomized phase 2. It was only 120 patients. Pem-carbo was the backbone, 4 cycles, followed by pemetrexed maintenance indefinitely, plus or minus Pembro. Pembro was grafted right onto that regimen and continued as maintenance with pemetrexed for up to 2 years. And here too, we saw a very marked improvement in outcome, a doubling in response rate from 28 to 56%, doubling in median progression-free survival. The latest updates show PFS approaching 20 months. Control arm doing as well or better than it had done historically at 8.89 months. Initially, no survival difference. 1 year, 75% versus 72%. But as time went on, the curves started to separate. And this is a pattern we've seen in many of the immuno-oncology trials where maybe not an immediate benefit in terms of PFS or median overall survival in some of these trials, but as once we hit the year mark, 18 months, 2 years, we start to see a separation. So the hazard ratio dropped from 0.9 to 0.69 to 0.59. Wasn't quite significant. It was a one-sided alpha, so even though the p-value was below 0.05, it could not be called statistically significant. But clearly hypothesis generating and clearly meriting a prospective randomized phase 3 trial to either confirm or refute these data.